بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will discuss this topic about the MR spectroscopy of the brain. And as you all know that the spectroscopic analysis of the brain entails the use of MRI to produce some sort of a curve that indicates the presence of some metabolites in the sampled brain tissue, and according to the peaks of these metabolites we can sometime know what is the underlying pathology. Then, as you all know, that the MR images depends mainly on the hydrogen nuclei, and the hydrogen protons are the most prevalent protons in the human body tissues, and of course they are present in very high concentrations, especially in water and in lipids. Then there are other metabolites that contain hydrogen, and these metabolites are present in very low concentrations. And in order to see these metabolites, we should suppress the very high signal of water as well as the signal of the fat. And this process is known as the chemical selective saturation radio frequency pulse. Regardless the name, but we should know that the hydrogen protons are present in the human brain, and is very sensitive. They are very abundant, and the brain tissue is ideally imaged by MRS because of the relative lack of motion. So the images and the spectroscopic curves will not be disturbed by the motion. And we should have a software specialized for this process, the MRS, and it's preferable to have a high strength magnetic field in the range of 1.5 Tesla. And the advantages of this high field are: number one is to have a higher signal to noise ratio, which is one of the very important issues in MR spectroscopy, and to get high resolution curves, and also to have a shorter acquisition time, which is useful in sick patients. Then you know that the protons are shielded by their valence of electrons, and every proton group has a slightly different magnetic field, which is different from the adjacent proton group. And every proton group resonates at a different frequency. And these differences in frequencies are usually measured as the chemical shift from a reference standard in part per million. I will explain this in details. Then, in order to demonstrate these very small resonance for each metabolite, and we use the setting of MR spectroscopy, applying an external magnetic field to make some little change in the resonances of the different proton groups, so that we can sample these groups via the MR spectroscopy. Then this scanning or sampling depends very much on the echo times, which can be short and can be also long according to the needs, as I will explain. Then if you have many proton groups and you apply an external magnetic field. This magnetic field will make with some disturbances in the resonance of the proton groups, enabling the MRI to separate them in a curve which can differentiate these proton groups even if they are very small and the magnetic field is also very small. This shift in the resonance frequency of different proton groups is known as the chemical shift phenomenon. Then we have two methods for obtaining an MR spectroscopy, and these two methods are number one, the breast technique and the steam technique. The breast is the abbreviation of point resolved spectroscopy, and the steam is the abbreviation of stimulated echo acquisition mode. And you know that this technique may use 190-degree pulse and two 180 degrees pulses, while the steam technique, which is more popular, and can be performed with very short TE times, uses three 90-degree pulses. And today, the breast technique is usually used for obtaining the MR spectroscopic imaging, and since it provides double signal to noise ratio, and then you will obtain high resolution spectroscopy curves. Then there are also two techniques performing the MR spectroscopy concerning the voxel. The voxel is the area that I put on the pathology so that I tell the magnet I am going to sample this particular area of interest. Then we have two types of voxels technique, the single voxel technique and the multi-voxel imaging technique. Both techniques can be performed at a short echo time and a long echo time, and this is usual while performing the MR spectroscopy. We should have short echo time spectroscopic curves and other obtained with long echo time. And this is what I mean by single voxel technique. This is the pathology and this is the voxel. And you put, of course, to perform the MR spectroscopy, you should have first an MR images, possibly the axial flare or other techniques, so that you can see the pathology. Then you select the technique you want, the single voxel. Then you put your voxel on the pathology and you start sampling. By the single voxel technique, the size of the voxel is usually fixed and it is in the range of 2 by 2 by 2, meaning that 8 cubic centimeters, and it can be obtained with the spectroscopy, can be obtained by short TE, and also it can perform with long TE. Then this single voxel technique is available in most of the scanners and it results in a high quality spectrum, as you will see. And one of the procedures or the rules whenever you are performing single voxel technique is to put another voxel on the opposite normal brain tissue, and so that you can compare the resultant spectrum from here and there, and you know the change in the pathologic area. And this is one of the drawbacks of a single voxel technique, that the voxel is sizable, and sometimes you are sampling a pathology which is less than the size of the voxel. Then you are sampling also an area of normal brain tissue surrounding the lesion, and this may result in normal appearance of the spectrum because of the partial volume that you have performed in the surrounding area. Then how to overcome this problem? If you decrease the size of the voxel, then you will decrease the signal to noise ratio, and you will need increase in the number of acquisitions. Or an alternative is to use the multivoxel technique, which use at least 16 voxels, and I will show it to you. Then you can sample the pathology and the adjacent brain tissue, and also the size of the voxel in the multivoxel technique will be reduced to half. It will be one by one by one in size. Then this is the single voxel technique, and the multi-voxel technique. This uses the short echo time, and this uses the long echo time. Here is the single voxel, and here are multiple voxels, and this will result in sampling a limited region, and in this area you can collect many data as I will show you. And then this is what I mean by the multivoxel technique. Here what looks like a grid, and you put this whole area including the lesion and also the adjacent brain tissue. Then you can select the sampling from any of these voxels, and you can select here at the central part of the tumor, and you can select this in the normal brain tissue. And this is the normal brain spectrum, and this is the spectrum of the tumor as I will explain. And by multivoxel technique, the size of the voxel is 1 by 1 by 1, 3 centimeter, 3 cubic centimeter, and you can use the same techniques. And this is usually known as internal reference because you are sampling the lesion and you are sampling normal brain tissue nearby, so they can compare. That's similar to the single voxel technique, but you apply a voxel on the pathology and another voxel on the normal brain tissue. Then here, if the lesion is very near to the calvarium or to the diploic fat or the CSF, these structures will disturb the spectrum. So we should have some sort of suppression of the fat and the fluids in order to obtain a smooth, high resolution spectrum. Then by short TE, we mean we use echo times in the range of 20 to 40 milliseconds. And this will have higher signal to noise ratio, and also will show many metabolites compared to the long TE. In the standard metabolites that will appear by short TE and long TE are three. Number one is the N-acetyl aspartate, and number two is the creatine, and number three is the choline. These are the fixed metabolites that will appear whenever you are using the short TE or long TE. But in short TE, you can see more metabolites with very short relaxation time, so that you can see here like myoinositol and glutamine and glutamate, and also the lipids and lactate. Then here is the long TE, which is obtained usually in the range of 135 to 144 milliseconds. And in the previous days, they used to have the short TE in the range of 20 to 40, the intermediate TE in the range of 135, and the long TE in the range of 288. But nowadays, it is a standard to use only two echo times, the short one and the long one, which is in this range. Then by the long TE, you will see the major three fixed metabolites, which are the N-acetyl aspartate, the creatine, and the choline. And this is the difference between short TE spectrum and long TE spectrum. In long TE spectrum, you see the major three metabolites, the NAA, N-acetyl aspartate, creatine, and choline. And then in the short TE, you see more metabolites like the lipids and lactate, and also you see myoinositol and some of the glutamine and glutamate peaks. Then how to obtain a good quality spectrum. Then number one is you should ensure that your magnet has a homogeneous field by shimming or by techniques that induce homogeneity of the magnet. Number two, and you ensure adequate water suppression so that you can see the spectrum of the very small metabolites. Then number three is to adequately adjust the voxel at the site of interest to have a spectrum which is free from artifacts. It's very important to avoid bones, to avoid metals, to avoid blood vessels, metals like the surgical stitches, sometimes some of the foreign bodies and others, blood products, air, CSF, fat, and the necrotic areas if you can, and also the areas of calcification. Then this is the normal MR spectrum using the long TE, which is in the range of 145, and short TE, which is in the range of 35 milliseconds. In the long TE, and you see the major three metabolites, the N-acetyl aspartate, creatine, and choline. In the short TE, you got more metabolites like lipids and lactate, glutamine and glutamate, and myoinositol. And you should know that the signal of water is 100,000 times greater than any of other metabolites. So that this is the signal of the water. If the water is not suppressed, you will not see any of the previously mentioned metabolites. Then use any of the techniques available in the magnet to suppress the signal of the water so that you can see these metabolites as I show you. And then if you look here, and this is the spectrum where you can see the major metabolites, the N-acetyl aspartate, creatine, and choline, and you see that the water signal has been suppressed. Then a good quality spectrum should present a flat horizontal baseline with distinct narrow peaks. So if you see that the peaks are broad and there is no distinct baseline, and you know that there is a problem with this spectrum. And what are the metabolites routinely seen in the brain tissue? These are the metabolites seen in the short and long TE include N-acetyl aspartate, creatine, and choline. And lactate will be seen on short and long TE if present. Lactate is not usually present in the normal brain tissue. Then what are the metabolites seen on only on short TE? And these are the lipids, the glutamine and the glutamate, and the myoinositol. These are the three metabolites that are added to the spectrum whenever you are using the short TE. Then let us have some information about the major metabolites in the brain tissue, starting by the N-acetyl aspartate. This is the highest peak in the normal brain, and it is located in the curve at this point, 2.02 ppm here. And the curve starts from the right to the left, starting by these numbers, which are expressed in part per millions, and you will see the N-acetyl aspartate peak at this situation 2.02 pm. And this N-acetyl aspartate is exclusively found in the brain tissue and in the spinal cord, of course, both in the gray and white matter. And it is considered a marker of neuronal and axonal viability. Then, if any pathology that can damage the neuronal and axonal viability, and this will result in a decrease in the N-acetyl aspartate peak. And you can consider decrease of NAA in every pathology in the brain tissue except for Canavan disease. And this is the only disease where the peak of N-acetyl aspartate is very much increased. And also, if you are dealing with a lesion that is not of neuronal origin, like the meningioma and the metastasis coming from outside the CNS, then you expect that you will not see the NAA peak. Then we came to the second peak, which is creatine, and creatine is present at 3.02 ppm, and this is a marker of energetic system and intracellular metabolism. This creatine is almost have no change in any situation in the brain tissue except very few lesions I will mention, and this is considered the most stable metabolite. Then you can use this peak as a reference to see how much the NAA has decreased and how much the choline has increased, because you will know in a moment that most of the lesions in the brain will decrease the NAA and elevate the choline peaks, and the degree of elevation is intimately related to the pathology. Then, if it is mildly elevated or uh, very much elevated, how can you judge? It's just by comparing the choline to the creatine, what we call the choline creatine ratio. Then, if you see that there is a little difference between choline and creatine, and this is a slight increase, very big difference, and you know that there is marked increase in the choline, and this peak is present at 3.22 ppm. It is just next to the creatine peak, and this will represent the or reflect the cellular proliferation. And the choline is almost elevated in every brain pathology except few I will mention, and hence the elevated choline is considered non-specific. Then you come to the lactate, and the lactate is not seen in the normal brain, but the site of the lactate peak is at 1.33 ppm here in this particular area of the curve. Then lactate is the product of anaerobic glycolysis, and it is increased in anaerobic metabolism like hypoxia, ischemia, mitochondrial diseases, acute inflammation, abscesses, areas of breakdown in the tumor, and inside the cyst, like hydatid cyst, for example. And this peak is doublet. Doublet means that it has two ABCs and in this area, and this lactate as I will mention immediately. Now, the lactate peak has two ABCs, and characteristically, this lactate peak, whenever you use the long TE spectrum, the lactate peak will be inverted below the baseline. And this is one of the characters that you are dealing with this peak, and you know that this is lactate because in a moment you'll see that there is another peak will appear here at 1.4, which is the peak of alanine, which has also two ABCs, and it will be inverted in the long TE spectrum. But alanine is very specific for meningioma. Then you should have a way to discriminate both, as I will mention immediately. Then lipids are usually located in very close situations in 1.3 and zero point 0.9 ppm, and the lipids are not present in the normal brain tissue. But lipids can be seen in necrotic brain tumors like glioblastoma multiforme, for example, and metastatic deposits. Then myoinositol is located at 3.56 ppm, and this is a glial marker being sensitized primarily by astrocytes. And this peak, which is not usually seen in the judgment of, uh, not usually used in the judgment of the brain lesions, for example, it is elevated in gliosis, inflammation, and in Alzheimer's disease. And this is the alanine peak I have mentioned in a moment, and this is located at 1.48 ppm. And this may be obscured by the lactate peak, which is located very close at 1.33 ppm. This peak has also double apices and is inverted with the long TE spectrum, and the alanine is very specific for meningiomas. And this is an example of a subfrontal meningioma showing homogeneous enhancement. Then you have a long spectrum, long TE spectrum at 135 milliseconds, and you see that the doublet peak of alanine has been inverted below the line. Then one may ask, how can you know that this is not lipid? This is not lactate peak, which is also doublet and is inverted in this long TE spectrum. I say that you go to the original MRI images. If you see that the voxel is present on a homogeneously enhanced lesion, then you know that you are dealing with a meningioma, and this peak will be alanine. But if the voxel is present on a necrotic area or an area of gliosis and so on, then you know that you are dealing with the lactate peak because of the appearance on the MRI. And you all know that we cannot interpret the MR spectrum without looking at the MR images. And this is another example of a meningioma. And you see this, the voxel is present in a if a good part of the tumor, and you see elevation of choline, which is not specific, and you see absence of NAA because this is an extra neuronal lesion, and you see the doublet peak of alanine with some lactate nearby, and you can see that the elevation of the choline and the presence of this lactate may suggest that this meningioma is of an aggressive nature. And glutamine and the glutamate are present very near to the N-acetyl aspartate at 2.05 and 2.50 in part per million, and they are elevated in few diseases like hepatic encephalopathy. Then to improve the quality of the spectrum, you have to increase the signal to noise ratio by one of two methods. Number one, increase the number of acquisitions. This will increase the examination time and give the chance for the patient to move. Then you can have many artifacts and very wrong spectra. The second way is to increase the voxel size, and if the voxel size is increased, it will be difficult to adjust the voxel to the site of the lesion, especially if the lesion is smaller than the size of the voxel. Then these are the diagnostic values of MR spectroscopy. Of course, number one in the diagnosis and the staging of brain tumors, and sometimes they say they are very useful in grading the tumors as well, and differentiating between tumor progression and radiation necrosis. This is a very important issue. Diagnosis of some types of leukodystrophies and may provide prognostic information in neonatal hypoxic ischemic encephalopathy. Again, as a general rule, the brain tumors will show decrease in acetyl aspartate, increase in the choline peak, and no change in the creatine. And if you look here, this is the normal spectrum of the brain with the highest peak in acetyl aspartate, then creatine and choline. But in brain tumors, you got depression or decrease in NAA peak, and the creatine is not changing, and the choline is markedly elevated depending on the grade of the tumor. And the major findings in MR spectroscopy of most of the brain tumors is decrease in acetyl aspartate, increase in the choline, and no change in the creatine. Then absence of NAA is usually seen in extraaxial tumors like meningiomas, like osteosarcomas of the calcareal bones, and also in brain deposits where, because these are of non-neuronal origin, and maybe also absent in highly malignant tumors with extensive areas of necrosis. Then the choline peak may help with the treatment response. If you see that the choline is high before treatment and the choline starts to decrease after treatment, and this indicates a good therapeutic response. And choline signal is constantly low in necrotic areas and may be absent if there is extensive necrosis. And this is an example of a glioblastoma multiforme in the left frontal lobe showing marginal enhancement of non-uniform thickness. And if you put the voxel at the edge of the tumor, it will include viable tumor tissue and areas of necrosis. If there are areas of necrosis, then you got elevation of the lactate peak. And because this is a viable tumor tissue, you got depression of N-acetyl aspartate, and you got some elevation of the choline compared to the creatine. If you look to the curve, and you cannot judge that this choline is high unless you compare the choline peak with the creatine peak, what's known as the choline creatine ratio. Then here is a diffuse astrocytoma showing low signal in the T1, high signal in the T2 and the flare with almost no contrast enhancement. And this lesion may be mistaken with a stroke, or sometimes if the focal cortical dysplasia may have, but this is very big to be diagnosed as cortical dysplasia. But in these situations, which are the glioma, the stroke, cortical dysplasia, if you see choline peak, this means that you are dealing with a neoplasm. And this is the diffuse astrocytoma. And in diffusion weighted images, you will got free diffusion, and by MR spectroscopy, you will got the usual appearance in gliomas, which is decrease in the N-acetyl aspartate, increase in the choline peak, no change in the creatine peak, and then we got some lipids, lactate, because of the areas of necrosis within the tumor. Then this is also a very important issue, is how to differentiate between abscess and the glioblastoma. There are many ways from imaging, from MRI. Abscess has a regular uniform thickness enhancing margin, while glioblastoma will have an irregularly thickened margin of non-uniform thickness. And both lesions are usually surrounded by extensive perifocal brain edema. On diffusion weighted images, abscess will show restricted diffusion while glioblastoma will not. But according to the literature, they said that some of the neoplasms may show restricted diffusion and may be mistaken for the abscess. Then the presence of choline favors a neoplasm, and the presence of lactate cannot differentiate between abscess and the glioblastoma, because lactates are usually seen in necrotic areas and also in cystic areas. But the presence of acetate, succinate, and amino acids at the center of the lesion denote that you are dealing with an abscess. Then this is an example of typical biogenic abscess in the right cerebral hemisphere. Low signal in the T1, high signal in the T2, surrounded by perifocal brain edema, and you got marginal enhancement of uniform thickness. Then the MR spectrum showed that this spectrum is obtained, of course, at long TA, and the lactate peak is inverted, and you got this succinate and acetate peaks, which are usually seen in cases of biogenic lesions. And here you can see the lipid and lactate peak at 1.3 ppm, the acetate at 1.9 ppm, and the succinate at 2.4 ppm. And this is also a spectrum obtained from the central part of a brain abscess in the temporal lobe. You see very high peak of lipid and lactate, and depression of all metabolites, the NAA, the creatine, and choline, are depressed. There is no tissue here. There is only pus. But if you have a spectrum from nearby the abscess and you got normal brain MR spectrum, and with elevation of the NAA and the normal peaks of creatine and choline. Then hydatid cysts behave almost like the abscess. If you put the voxel within the cyst, you will got similar to an abscess. In here, you can reach the diagnosis of hydatid cyst simply from MR images by the presence of an intraaxial cystic lesion, which is not usually surrounded by edema and show no contrast enhancement and exerts little mass effect according to the size of the tumor of the cyst. And here you can see no peak of NAA, no peak of creatine, no peak of choline. Then you got some peak of lactate, which is the doublet peak, indicating that you are dealing with a cystic lesion or an abscess. Then this is also the hydatid cyst spectrum of hydatid cyst. And you got succinate, you got acetate, and you got the doublet peak of lactate. Then this is an important issue also, how to differentiate between glioblastoma and metastasis. Both lesions can show marginal enhancement of non-uniform thickness. Both lesions can show diffusion, free diffusion on diffusion weighted images. But spectroscopy is unique in this particular area so that you can differentiate between the glioblastoma and metastasis by putting the voxel near the edge of the tumor, outside the edge you see on MRI, and in the sample this area. If you got tumor, say tumor spectrum, meaning that you got decrease in NAA and the elevation of the choline and some of the lipids and lactate, then you know that this lesion is glioma, because you know that the glioma edge is not indicated by any kind of imaging. The edge of the tumor is diffusing through the brain parenchyma, and we all know that this is not the actual margin of the tumor, it is beyond the margin that we can see on imaging. On the opposite side, if you put the voxel outside the margin of a metastatic deposit, you will got normal brain spectrum, increase in NAA, creatinine, and choline. And this means that the metastasis has a well detectable margin on imaging, but glioma has no detectable margin on imaging. And this is an example. And you see here, this voxel is on the brain tissue normal, and you got normal spectrum. And this voxel and this one are placed on the enhancing part of the tumor, and you got tumor spectrum. But if you put the voxel near the margin of the tumor. In glioma, you will got also a spectrum of glioma, but in metastasis, you will got normal brain spectrum. Then the discrimination between low and high grade gliomas is usually debatable. And you remember from my lectures about the imaging of the brain tumors that we have, the gliomas are divided into the low grade and high grade, and included in the high grade the anaplastic glioastrocytoma and the glioblastoma multiforme. Of course, they said in the literature that the elevation of the choline has uh, uh, um, some intimate relation to the grade of the tumor. If the choline is markedly elevated, then you know that you are dealing with a high grade tumor. If not, then you are dealing with a relatively low grade tumor. And in order to have a good judgment, you should have the ratio between the choline and the fixed peak of creatine. Then choline creatine ratio will tell you what is the grade of the tumor most likely you are dealing with. Then threshold value of 2 for choline creatine ratio is used to differentiate the low grade from high grade glioma, meaning that if you divide the peak of choline by the peak of creatine and you got more than 2, then you are dealing with a high grade tumor. And here are the spectra obtained from low-grade lesion. You see the lactate is high and there is some elevation of the choline compared to the creatine. But in the high-grade tumors, then you got marked elevation of choline compared to the creatine. Then accurate grading is usually difficult if you use only MR spectroscopy. But the literature always indicate that you should use the MRI with contrast enhancement and look for the edema, look for the necrosis, look for the hemorrhage, look for the mass effect, look for the perfusion of the tumor. Then you can differentiate between the high and the low grade tumors most likely. And the choline creatine ratio of more than 3 indicates that the tumor is progressing, while a ratio less than 2 may suggest that you are dealing with tumor necrosis. And if you look here and you have two spectra, one from the normal brain tissue on this voxel, and you got the normal spectrum, and one from the tumor, which is present here, and you got very, very marked elevation of the choline compared to the N-acetyl aspartate, which is markedly depressed, and this is the peak of creatine. Then you can use the MR spectroscopy to have what's known as choline maps. And you can use some software to look where is the high concentrations of choline, which indicate that you are dealing with in these areas of high choline, we are dealing with viable tumor tissue. If you look here and this area represent the highest concentrations for the choline. If you look carefully for this particular area, and you can appreciate that this area in particular is not enhancing here, and it is not included in the tumor considering the MRI. And this is the value of MR spectroscopy, and you can appreciate the presence of high choline outside the margin of the tumor, indicating that you are dealing with a malignant glioma. The lymphoma will show the same changes in MR spectroscopy, decrease in NAA and increase in the choline relative to the creatine. But you can also appreciate the diagnosis of lymphoma if you use the diffusion weighted images, because you know that one of the tumors, well-known tumors to produce diffusion restriction is lymphoma because of the marked cellularity of the tumor. In glioblastoma, gliomatosis cerebri is usually classified by WHO to have many grades 2, 3, and 4 according to the the histologic findings. Then marked elevation of myoinositol and creatine are found in high-grade tumors of gliomatosis cerebri. Then here, this is a infiltrating glioma or gliomatosis cerebri, low signal in the T1, high signal in the T2, and the high signal also in the FLAIR images with some restricted diffusion in diffusion-weighted images. The MR spectrum show decrease in the NAA and increase in the choline, which are defining usually present in brain tumors. Oligodendroglioma, the same. Oligodendroglioma is considered now one of the intermediate grades. It is not a low grade as was thought before, and you may got significant elevation of the choline and choline creatine ratio in oligodendroglioma. And you know that diagnosis is based on the presence of a tumor with internal calcification, and calcium is usually seen by CT, and they may be sometimes indicated by MRI. In oligodendroglioma, you got also decrease in the NAA, and this is the creatine peak with elevation of the choline similar to any of the tumors. And this is also one of the values of MR spectroscopy is to differentiate between tumor recurrence and radiation necrosis. In both cases, in tumor recurrence with areas of necrosis and gliosis, radiation necrosis, both lesions will contain or will show elevated lactate and lipid peaks. But how can you differentiate? It is the choline and choline creatine ratio and choline N acetyl aspartate ratios. Then look here, and this area is an area after treatment of an infiltrating glioma, and this voxel is sampling normal brain tissue, and you got normal spectrum, and this voxel is sampling the lesion, and you got this very characteristic appearance of radiation necrosis, which include elevation of the lipid and lactate peak and depression of all metabolites. You don't see choline nor NAA, all the metabolites are depressed. And here, you know that radiation necrosis may simulate the glioblastoma multiforme exactly on imaging. And whenever you put the voxel of MRI of the spectrum here, and you got no metabolites, minimal, no NAA, the creatine and the choline is depressed with elevation of lactate. Lactate will be elevated in both tumor recurrence and radiation necrosis. And some errors of metabolism can be diagnosed by MR spectroscopy, especially the creatine deficiency, which is one of the well-known lesions where MR spectroscopy can help. And you know that creatine signal is a constant peak in the MR spectrum. And in cases of creatine deficiency, we have three types. Two of these types are caused by mutation in the enzymes responsible for creatine synthesis. And these two diseases can be treated by oral administration of creatine products. Then the third type is an X-linked disease that prevents the uptake of creatine into the cells, and this type cannot be treated by oral supplementation with creatine. Then if you look here to the, this is normal brain tissue, and you put the voxel here and you don't see the peak of creatine. Then if you give oral supplements of creatine and you repeat the MR spectroscopy, then you got the normal creatine peak, and then you know that you are dealing with the first two types of the disease, which are responsible for these enzymes preventing the creatine synthesis. Then also you remember the adrenoleukodystrophy is one of the leukodystrophies which can be easily diagnosed from imaging, especially when you see the changes of the white matter which are confined or most mostly present in the posterior parts of the brain, and whenever you inject contrast material and you got enhancement of the what is known as the leading edge of the disease. This is an X-linked leukodystrophy commonly seen in boys between 3 and 10 years of age, symmetric lesions in the bright occipital areas. Enhancement of the leading edge or the advancing edge is characteristic, and sometimes you may see calcium. What's important about MRS is that MRS can see the changes in the brain tissue before these changes appear on the MRI. And this is also one of the diseases where MRS is very helpful, which is the Canavan disease. Then Canavan disease results from deficiency of this enzyme, which will lead to accumulation of N-acetyl aspartate in the brain tissue and also in urine. Then if you perform an MR spectrum, you got these changes which are seen in the imaging, CT and MRI, and you cannot in many times differentiate these changes from the rest of the rest of leukodystrophies. But if you see here, and the accumulation of NAA in the white matter will lead to cystic changes or what's known as vacuolations of the white matter, which represents dilatation of the Virchow-Robbins space. And if you have an MR spectrum, you got marked elevation of N-acetyl aspartate, and this is almost the only disease where the N-acetyl aspartate can be elevated, such an elevation. Thank you very much. Alhamdulillah Rabbil Alameen.